Welcome, everyone. My task in the next period of this talk is to talk to you a little bit about personalised medicine, both in the context of common disease risk and then briefly in the context of pharmacogenomics. I suspect you'll ascertain rather quickly that I'm not, as you say, a proper doctor. I'm in fact a statistical geneticist, and I work up at the Wellcome Trust Centre for Human Genetics. And I've spent a lot of my last 5 to 10 years involved in these studies which try and collect large-scale genetic data and try and associate that genetic data with diseases and other clinically relevant phenotypes. And to delve a bit deeper into what sort of information is available and how that might be used, I thought I'd start by telling you a little bit more about how we do these studies. So I'm hoping this cartoon is going to be helpful. What we're doing here is looking at a very small part of the human genome, perhaps in the middle of chromosome 20, say, where each of the lines along here represents an individual in that part of the genome. And as Professor Donnelly mentioned, that typically how we conduct these studies is to collect both individuals with a disease and then individuals from the general population in order to compare their genetic makeup and look for disease association. So for example, in this part of the genome here, across these 12 individuals, there's a genetic polymorphism where some individuals carry a G allele and some individuals carry an A allele. And to help us see that on a larger scale, I'm going to turn that into a cartoon and just replace those polymorphisms with blobs. So here's a part of the genome that you were just looking at with the A and G alleles. And each of these other blobs represents other parts of the genome where individuals differ from one another. And the statistical game that I get to play at work, which I've enjoyed and continue to enjoy, is to walk along the genome using this genetic data to try and find positions in the genome where individuals with a disease carry alleles more often than they do in the general population. Why is that informative? Well, if that evidence is strong enough, that's the first inkling to us that it might be something about carrying this polymorphism which increases your risk of disease. So literally what we do then with a computer is walk along the genome, looking at hundreds of thousands of positions across the genome in thousands of individuals to look for a statistically significant difference between these two groups of individuals. So for example, we might look at this polymorphism here and notice that it occurs 4 out of 6 times in the diseased individuals and 3 out of 6 times here. That's not such a big difference, and we can test that statistically, and we do that at each of these positions until we find a position in the genome where that evidence gets strong enough for us to get excited, and then we give ourselves a little pat on the back. So it's these sorts of studies, and it's this sort of analysis that's led to this complete change in what we understand about the contribution of common genetic variation to common diseases. So this is a slide, if not exactly the same, very similar to the one that Professor Donnelly showed earlier, where the whole genome is littered with parts of the genome where genetic variation affects disease risk. So we know thousands of those for hundreds of diseases. For some diseases, we only know a couple. For others, we know somewhat more, 20, 30, 40, 50, and I'll talk about that a little bit more in a minute. So how does that relate to kind of predicting or thinking about the impact on an individual's disease risk? Well, these very same studies, once you're convinced that an association is real, can be used to make some sort of quantitative assessment of how predictive that polymorphism is. So in my tiny little cartoon before, you may remember, perhaps if you've only got a photographic memory, but I'll convince you anyway, that in the disease group, 5 out of the 6 individuals carried this red polymorphism, and only 1 in 6 of the individuals in the general population carried this risk allele. So it's these sorts of quantities that we can use to turn these genetic data into an assessment of how polymorphisms affect your risk. And I'm going to refer to that something as a relative risk or a relative increase in your risk that's quantified on the basis of knowing how much more increased in frequency susceptibility alleles are in individuals with disease as compared to the general population. Now, it was true in my example, and it's generally true to note, that for these polymorphisms, it's not true to say that if you have the risk allele, you'll get the disease. The information here is much more subtle, and it's typically subtle in this way, such that if you were to genotype me, and I had this red allele, or 1 copy of this red allele from the 2 genomes that I inherited from my mother and my father, typically in these sorts of studies, those genetic variants only increase risk by, say, 20%. So the relative risk here is 1.2, and that equates to a 20% increase in risk. How is that relevant? Well, my absolute risk of disease is my risk before I looked at my genetics multiplied by this new information I have about how my genetics impacts on risk. Okay? So just to put this into kind of the bigger picture, and Peter described different parts of this chart up here to you, we can think about how frequency of disease mutation and these relative risks fit together across the full spectrum of genetic influences on disease. The part that I've just told you about and the part that I'm going to talk about in this little snippet are the genetic mutations that are actually quite common in the population, say up to 10%, 20%, 30%, so they're very common. Most of us here all of us here will carry very many of them, but individually, they tend to have a very low influence on risk, okay? And that sets them apart from Mendelian diseases, where the mutations such as cystic fibrosis are typically very rare, but are very predictive of disease, okay? So, exactly because these risks are small, we've had to conduct very large studies to find them. And one consequence of having to do very large studies is that we have to get the cost down low enough to be able to do them. And because it was demonstrated that if we could do big enough studies, they would be powered in this scenario, then there was a big driver on the technology companies to facilitate us with a technology cheap enough to allow us to do these studies, and that's exactly what's happened. So what you're looking at here is a tiny little microarray chip. You can just about make out a thumb here, so that gives you a sense of size, which actually analyzes, I think, 12 individuals simultaneously at 500,000 positions across their genome, which we know to be polymorphic. So what's now possible in 2013? Well, I've already told you that there are thousands of genetic variants associated with disease, and that through these studies and developments in technology, we can assay them accurately and cheaply, okay? And that it's relatively easy to use this information to turn an assessment of your genetic makeup into some quantitative statement about how that's going to influence your personal disease risk. So we're not the only people to notice this. Bright people, typically in the west coast of California, also notice these sorts of things, and they also notice that people might be interested in these sorts of information based on their own genetics. And there's now a whole range of companies that will offer to ascertain and analyze this information for you. I'm going to tell you a bit about that as a kind of example to drive home the fact that what's really possible now quite cheaply and quite effectively, and to raise some of the issues around what the consequences might be, therefore, to the individual, and bringing this into healthcare. So how do these companies work? Well, you go on the web, you Google for them, and you'll find a whole bunch of them. You can order a kit that's sent to you, which includes a little spittoon, and you spit in a spittoon, so you spit in it, and you send that back to the company. They'll then extract your DNA, and they'll run that DNA analysis on exactly the same technologies that we use to do this large studies that I've just described. And then they will send you a digestion of that information back to you via a web portal, just like your bank account or your Facebook page or so on and so forth. And these companies differ, but they typically give you two bits of information, one about your health risks, and I'm going to go into that in a bit more detail in a minute, and one about your ancestry or where your ancestors are likely to have come from based on your DNA. So am I qualified to talk about this, or do I have any experience of this? Well, yes, I do. I'm going to tell you a bit more about that in a minute. But I first want to drive home, as part of articulating how feasible this is, that this doesn't cost thousands and thousands of pounds. One of these companies will do this for $99 now, including shipping, and they do it without any need to involve a healthcare professional. I can just go up, sign up for it, order it, get it back, and log in and see my results. And this isn't just something that 1 or 2 or 3 or 4 people are doing. One of the companies that I'll talk to about more in a minute probably already has about 500,000 people typed with this technology, and in 2014 they aim to have 1 million people, and they're probably on target to do that. So these aren't one-off companies who have got nobody looking at their data. One of those customers is me. So this is actually a web page, me accessing my own results. If you don't believe me, it says Chris Spencer up here, and I haven't doctored that. Just to give you a sense of how you can access this sort of information. The bit that I'm going to talk about most, of course, is health overview. If you're looking at this somewhat more carefully, you may have noticed that I'm 2.6 Neanderthal DNA, and you may be worried about that. In fact, I'm very proud to say that the average person is 2.7% Neanderthal DNA, so I'm, on average, less Neanderthal than you guys are. So to illustrate this example, I don't really want to use myself, so we're going to make a contrived example just to explore some of the issues around individuals having this sort of information. So this individual is male, they're 45 years old, they're Caucasian, and they've had no real previous health concerns other than this individual's father died of a heart attack age 55. And they got interested in this area through watching a TV program, probably on Channel 4, about genetic ancestry and wanted to learn more about their own ancestry. So looked up and chose this company called 23andMe. Many other similar companies exist, and I'm not funded by any of them, so please don't see this as an advert. So let's imagine that he does this, and he gets his result, and instead of being interested in the ancestry, which is why he originally bought the test, he sees that his health risks are reported to them, and focuses on them without much thought. Now, because of, we've already told you that we now have genetic information on hundreds of diseases, and the typical way these companies report it back is by giving you a ranked list of the diseases that you're most at risk for at the top. Okay, and so they're the things that your eye is naturally drawn to. And what I'm going to talk about here is a contrived example, but I hope it's not too distant from reality to make the points I want to make. So this is the sort of information this individual might be exposed to. So I've got 4 categories of risk here for 3 different diseases, and I've blanked out some of the information to recapitulate the fact that this individual's eyes might be drawn to some pretty scary things from his point of view. So first of all, he sees that his absolute risk of coronary heart disease is nearly 60%. He's more likely to get it than not, okay? And he may not have realized, he may not think about that much, and that might be pretty scary. He might also find out that he's in the top 1% of risk for everybody in the population for multiple sclerosis, and that compared to the average person, he's 10 times more likely to get glaucoma. So all those things could be, or might be slightly scary, and we're going to try and explore some of that in the next few slides. And in this example, let's pretend he panics. He phones up his GP, says, I need an appointment straight away. Receptionist says, is it an emergency? He says, I don't know. They say, okay, well, let's make an appointment anyway. And he prints out this report and he rushes to his GP. Now, I'm not a medic, and I'm not quite sure what a typical reaction might be, but I don't think it's too far from the truth to say that most GPs won't have heard of 23andMe, and perhaps won't have heard of these companies at all, and they may very naturally be skeptical about this information and whether it actually represents anything real at all, and whether it really is anything other than snake oil. And one point I want to make is that doctors are actually already extremely well equipped to help individuals think about this information, because they're already pre-trained, and actually what they do, or what I imagine they do, is to constantly use information about risk to make decisions. What do I mean by that? Well, let's go back to this table now, but fill in some of the other statistics. First, for coronary heart disease. Now, what a doctor can help explain is just because of his age and gender, before he did the genetic test, he was already 46% chance lifetime risk of coronary heart disease. So this 58% risk really isn't that scary, and only actually involves a 20% increase to that background risk. The same sort of true for multiple sclerosis, in that even if he was in the 1% of the population and had an 8-fold increase in risk, because of his age and gender, his risk is actually already extremely low. So although this absolute relative change in risk is rather large, his new risk after looking at his genetics is still only 2.4%, and so on and so forth. And I think doctors are very used for thinking about this. So an important point I want to make is that, and I'm slightly biased, but I hope not completely biased, that this genetic information isn't rubbish. I've been involved in the studies to some extent, and it's real. So there's some caveats which I won't go into now. I'm happy to talk about them later, but the information is real. And so this part of it, the genetic companies tend to get right. But what they definitely do get wrong is, from a clinical perspective, is the individual's original risk. Because typically these companies will only use gender and age to assess an individual's lifetime risk before they did the genetic test. And of course, what we know is that their real risk before they did the genetic test depends on all sorts of things that haven't been accounted for here: family history, previous symptoms, lifestyle factors, weight, smoking, occupations, and so on. And these sorts of factors are exactly the sort of thing that medics are able to use to assess individuals' risks. So that then means that this absolute risk and this population risk aren't really right, because although the genetics is right, this bit isn't right in the first place. So just to summarize this first part then, there's a wealth of genetic information out there for us to use. Much of the genetic effects are small, and for most people, for most diseases, their genetic risk will be average. But it's interesting to consider as we go forward whether knowing the diseases which you in particular are most at risk of might be useful. And of course, what we really need to do to translate this into the clinic is get both of these things right. And we can only do that by integrating the genetic information with clinicians that are already used to building in weak information to make clinical decisions. So I really think for us to get this recipe right, and if we believe that absolute risk or some assessment of absolute risk is the right thing to measure, this will only really become properly personalized in the way we want it to when we integrate these things in the right way. So I think that it probably brings up a whole range of issues for us to discuss later. Some of them are up here. But what I hope it's done is driven home the fact that this information is here now, and it's very cheap to assay, and if you want to, you can go and access it well, within the next couple of weeks. So that's the end of my kind of spiel on common disease genetics. I'm going to switch focus now to talk about something called pharmacogenomics. I had to check 3 or 4 times that I'd spelled this correctly, and I hope I got there in the end. It's a long word, and it's very related to what I just talked about, but it's different in that instead of thinking about disease risk, which is the clinical phenotype, we're going to think about an individual's response to drugs, which is another clinical phenotype. I nicked this slide from Ingrid, and I think it's very helpful. This cartoon, what it shows is that out here in the audience and in this cartoon, our genetics not only determines our disease risk, but it also determines how we respond to drugs. So some individuals, like this individual, to some drugs, because of their genetics, will not respond to treatment or are much less likely to respond to treatment. And some individuals, like this chap over here, may or may not respond to treatment, but whenever they receive the treatment, they get an adverse side reaction, which may, in a lot of settings, be quite life-threatening. So the same studies that we use to assess common disease risk can be used to assess individual personal risk of response to drugs. And the example I'm going to use is hepatitis C infection. So here's some facts about hepatitis C. It's caused by a virus. It can make you quite sick. It's reasonably common in the UK. And treatment can clear the virus, but the treatment is expensive, it's unpleasant, and it may not work. Okay, they're the 3 things you need to know. And there's some quite scary numbers about how much treatment costs here just for the drugs, let alone for the clinical care that goes with it. So let's take another example. This one's somewhat similar to the other in that he's male and 45 years old, but this time he's Afro-Caribbean, and he's been diagnosed with hepatitis C. In fact, using a genetic test, he's been diagnosed with a specific type of hepatitis C, type 1. And the reason I've chosen these examples is because the fact that he's male and 45 years old and have hepatitis C virus infection type 1 actually makes him pretty unlikely to respond to treatment. The other thing that makes him unlikely to respond to treatment is that he's African American. So what this plot shows is that this SVR thing is effectively your chance of being cured by long treatment regimes. And you can see that African American individuals have a much less chance of responding to treatment than Europeans or Asians. And for a long time, the basis to this difference in response wasn't known. So he might have a discussion with his specialist who will point out that he's got 40% chance of not responding to what's not very pleasant treatment, and that one option to him, because he was otherwise healthy, was to wait for new and better treatments to come online. But let's go back to this cartoon. It's the same one you've seen before, but instead of disease and non-disease individual, we've now got responders and non-responders, and we've used exactly the same studies to try and find genetic variants involved in treatment response. This has been incredibly successful in the context of hepatitis C, because there's a single genetic variant on chromosome 19 near a gene called IL-28B, another kind of unmemorable gene, which has a huge effect on your chance of responding to treatment. So if you have the TT genotype down here, you've got less than 30% responding. But if you've got the favorable CC genotype, suddenly your chance of responding goes up to near 80%. And the interesting thing here is that actually on the bottom of the plot I showed you before was the frequency of this favorable C mutation in these different populations. And this single genetic variant explains half the difference in treatment response between Africans and Europeans. So you can imagine what can happen now that this individual, having thought that he might not respond to treatment, can be genotyped directly for this SNP, and if he's got the favorable genotype, his overall risk of being cured by this treatment might go from 40% to 80%, just by looking at this single genetic variant. I'm not going to go into detail here on this slide, but similar studies have been done to look at side effects. And a common side effect for this unpleasant treatment is anemia. And the anemia can be so severe that it can cause you to stop treatment. And of course, you can apply exactly the same methodology, and they've done that in this context, and found, again, single individual SNPs, which actually have a big effect on how likely you are to develop anemia as part of your treatment course. So then when we consider the decision of whether to treat or not to treat, this genetic information really helps us personalize care to this patient, okay? Because the genetic variant, rather than having to base decisions on how likely he is to respond just because he's Afro-Caribbean, can specifically look at this SNP to get a much, much better estimate of his chance of responding, and equally his chances of developing adverse reactions. So this seems kind of clinically relevant, and we should be using this sort of information, but is it readily available? How much does it cost? Well, those of you with eagle eyes might have seen on the previous slide that as well as reporting health risks, this same company, for the same $99, will tell you the SNP that determines your response to hepatitis C treatment and your likely chance of developing side effects, just as part of what they're doing, as well as other potentially clinically relevant phenotypes. So there's information there to be used, and this demonstrates, I think, the fact that you can do this for $99, that it's definitely possible, and it's actually not that expensive. So I think I'll stop there. I'll put up another set of questions here related to other questions, but try to bring out the issue of quite how close we are and quite how much we really should be using pharmacogenomics in standard clinical care. And I'll stop there. So that was my section on personalised risk and in common diseases and pharmacogenomics, and it's a pleasure to hand over to my colleague Gabe to talk about diagnosis of a rare disease.